And if you're having any tech issues, please utilize the panelist chat found at the on the side of your Zoom window.
Why is this?
Dr. Williams, I'm going to go ahead and turn your camera off so that we can go ahead and get started. And please feel free to use the chat to inform us of your timing.
Okay, hold on a second.
And mute.
Dr. Williams, I'm going to go ahead and turn your camera off so that we can go ahead and get started. And please feel free to use.
Okay, I think we will start. It is 3 o'clock according to my computer, and we have a packed agenda. Welcome, and thank you for attending the Regional Response Team and PrepareSTL panel, Making Sense of the COVID-19 Vaccine. Please note that today's session will be recorded and live streamed on YouTube and Facebook. My name is Serena Muhammad, and I am the Managing Director of the Regional Response Team. The Regional Response Team was established to coordinate a social service response to COVID-19 for vulnerable populations in a 5-county region. In this joint vaccine education campaign, our goal is to help organizations build their capacity to improve public accountability. By doing this, we hope that organizations will examine their policies and practices, culture and values, and relationships with staff and clients in order to support individual and community well-being. My hope is that today's session will afford all of us the opportunity to hear different points of view, challenge our thinking, and begin the important work of improving our organizational infrastructure and systems so that we can be better servants worthy of the public's trust. We have nearly 500 people registered for today's event. During the registration process, we asked you to share your top questions about the COVID vaccine. The question that we received the most was, how do I convince my employees to take the vaccine? Followed closely by, how do we get Black and Brown people to take the vaccine? Our simple answer to both questions is, you don't. As leaders and decision makers of social sector and public health organizations, we ask you to be careful not to exploit the power imbalance that is inherent in the employer-employee relationship. Our job as leaders is not to persuade, pressure, or push people to make a decision. As people who supervise and manage essential workers and frontline staff, we are in the highest service to those who directly serve others when we simply respect individual agency and support personal choice. To be clear, the Regional Response Team and PrepareSTL will not direct people to take the vaccine. We will not shame people who are reluctant to take the vaccine or alienate those who do choose to take it. Instead, we will create a safe space for all of us to have an honest conversation about the COVID vaccine so that we can better support people's ability to make the best choice for them and their loved ones. We believe that with transparency, honesty, and accurate information, people will be better equipped to make this important decision, and that is what we will endeavor to provide. In today's session, you will learn the basics of vaccine development so that we can all better understand the science. You will learn why context is important and why relying on the vaccine alone as the path to normalcy and wellness is not enough. You will also get a preview of how the states of Missouri and Illinois are approaching vaccine distribution and where you can go to continue to find real-time information about the COVID vaccine. I would like to emphasize that today we are having a point-in-time conversation. What we know about the vaccine and even the distribution plan changes rapidly and daily. The information we are sharing today could be updated by tomorrow. It is important that we all stay engaged in constructive conversations about COVID and the COVID vaccine so that we can learn and share information in real time. Today's session is the first in a series of panels, digital content, and other resources to educate service providers and the community at large about the COVID vaccine. We hope that you will continue to be engaged. We will share more about how the Regional Response Team Collaborative Action Network will support an ongoing learning community and help organizations build their capacity to improve public accountability and build trusting community relationships at the end of the meeting. At this time, I would like to introduce our co-host, Sierra Walker, to give welcoming remarks from our partners at PrepareSTL.
Thank you, Serena. Greetings, everyone, and happy Friday Eve. Thank you so much for joining us in today's conversation. I have the privilege of introducing to some and reminding to others the PrepareSTL campaign. My name is Sierra Walker, and I serve as an organizer for the campaign. In the short time that I have before you, I'll share a high-level overview, not only of how we got started, some of our partners, the model, and a little bit about the work that we've done thus far. Before beginning, however, I would like to elevate the comments of Serena and be explicit in affirming the notion that the COVID-19 vaccine and conversation in general has been very confusing for many of us, including myself. So PrepareSTL acknowledges and validates the lack of trust that has stemmed from the untreated, unhealed, and unresolved trauma that comes from the communities that many of us are serving. So because of that, PrepareSTL positions ourselves as a neutral source. We are here to support, not suggest. We respect your individual agency and will not endorse or encourage you to take the vaccine. Encourage what we hope is to disseminate equitable information that allows you to make an informed choice and the best choice for you and your family. So now I'll get started with talking a little bit about PrepareSTL, but again, it will be brief. The campaign launched in March of last year, and it serves as a unified campaign for communications and outreach. We focus particularly on those that are most vulnerable to the COVID-19 pandemic, and in our scope of practice, that means Black and Brown individuals, as well as those that are foreign-born. Our footprint of work also spans in St. Louis City and St. Louis County. We've set the goals to do two specific things throughout our campaign. The first is to make sure we can aid in stopping the spread of the coronavirus within our target audience, but also being very responsive and present to the needs that may span socially, economically, emotionally, mentally from those that have been impacted. When we got started, our campaign is comprised of several community and public health infrastructure. That includes the City of St. Louis Department of Health, the City of St. Louis County's Department of Health, St. Louis Integrated Health Network, the St. Louis Regional Health Commission, the St. Louis Community Health Worker Coalition, Alive and Well Communities, the St. Louis Mental Health Board, and we will be remiss if we didn't mention the T, who serves as our operational partner, and Dr. LJ Punch, who serves as our physician consultant. So now you might be wondering, okay, well, what makes this campaign or this model so unique? Well, we've had the opportunity to really be intentional about the model that we've created and combine three very critical components. We not only talk about public health education, but we're intentional around our community action and engagement efforts, which involve events and PPE distribution. And we've also provided economic relief to community members who've engaged with our campaign and have been negatively affected by the pandemic. So very quickly, before I turn it over, I will talk very, very brief about the work that we've done in this 9 months of functioning. At high level, PrepareSTL has distributed almost 200,000 cloth masks and filters across the St. Louis City and County area. We've engaged with over 160 organizational partners to do this work. We've engaged over 160 community members who served as canvassers and went out into the community to put up public health information. And we've interacted with over 625 businesses that maintained their operations during the shelter at home restrictions, and we put up public health information there. So if you were to think about this timeline in terms of months, we kicked off our campaign in March, and that served as phase one. So between March and I say May, we really focused on making sure we positioned ourselves as a source of factual information for COVID-19, the outbreak, the regional shutdown, and what it meant for reopening. Well, at the start of June and it spanned into July, we recognized the need to really emphasize the language of the dual pandemics, to support those who were engaging in protests, and to carve out intentional activities for our foreign-born communities. And then in August, we picked up a very massive campaign that distributed, like I said earlier, a little over 160,000, close to 200,000 cloth masks to residents of our St. Louis City and St. Louis County. And then that spanned until the closing of December. So now here you are, and you find us not only providing neutral information around the vaccine campaign, but we also are very, very serious about making sure that we keep our community prepared and set them up in a position to prevail. So with that comes an overall focus on healing, health, and wellness. So remember, the work of PrepareSTL was developed out of passion, not mandate. We also are committed to making sure that you stay prepared in all aspects. So if you'd like more information, please feel free to visit PrepareSTL.com. We keep it updated. You can find resources. You can even find a little bit of fun stuff if you visit our holidays tab. And in closing, I just say, remember that we stand by you and we stand with you. Thanks, Serena.
Thank you, Sierra. We appreciate the partnership with PrepareSTL. I'm going to turn it over to our moderator, Karen Bradshaw, to take us through the rest of the event. Karen is a campaign manager with the Regional Response Team.
Thank you so much, and thank you all for joining us today. We truly value you logging in, you taking the time, you sending questions ahead of time. This is really the start of a longer term conversation, a longer term creation of a space for that conversation. I want to acknowledge that we have had well over 450 questions submitted ahead of time. The Q&A function is open in the webinar today. You are welcome to put questions in there. We are keeping and tracking all of them. And I am fully able to tell you we will not address them all today. Many of them were similar and have similar themes, and we will certainly try to touch on them, but we will not get to every single question. However, we want to start the conversation. We want to have this be a start from both PrepareSTL and RRT today. As I got a chance to review all of the questions submitted, there is a wide variety, and people come to this conversation from different starting points, and we want to value all of them. We want to acknowledge that this, again, is to provide information. It is to provide a space for conversation. So we are going to get started. I have the privilege of introducing you all to our panelists today. We have 4 panelists. We are going to divide our time today with groups of 2 panelists at a time. We'll be starting this right now with Dr. LJ Punch and Dr. Stephen Liang. Sierra already provided an intro to Dr. Punch. They are the founder of Stop the Bleed and the Physician Consult and the T, vital organizations in this community, as well as being the physician consultant to PrepareSTL. Dr. Stephen Liang is an infectious disease doctor and an emergency room physician at Barnes-Jewish Hospital, and is associate professor for medicine at the Washington University School of Medicine. I'm also pleased to say that Dr. Liang and another colleague of his, Dr. Nolan, have provided the campaign that I work with the regional response team, focused on medical, behavioral, and substance use supports for those folks in our community who are unhoused. A lot of technical support, meeting regularly with shelter providers in our region, and providing valuable insight, information, advice, and guidance on COVID mitigation, and now beginning those conversations on vaccine as well. So I have the immense privilege of turning it over to Dr. Punch to get us started today and really talking and grounding us in informed choice.
Thank you so much for the chance to share with you all today and to join in such a committed, beautiful group of folks. I feel connected to everyone on this panel in such a unique way. A little tidbit, Dr. Liang and I did residency together, so it's just a joy. Next slide, please. So as we get started, there are some questions that you might want to see answered that Serena has already mentioned. What are some effective and accurate talking points to encourage reluctant individuals to get vaccinated? How are organizations working together to address messaging for marginalized communities? And what public health campaigns are being organized to build trust in the vaccination? Next slide. I want to present a reframing of that narrative that moves the power of choice to the community and the individual by supporting informed choice. SARS-CoV-2, the novel coronavirus, which causes COVID-19, has presented a never-before experienced challenge to humanity, our health, and our immune system. That challenge is not going to end anytime soon, and possibly never. And there is still so much to learn about the virus and how we can support our immunity, our overall health, and well-being. Historic and current racial medical trauma presents unique challenges as well. And the medical profession has an ethical obligation to support autonomy, the foundation for informed choice. By reframing the narrative with a focus on that autonomy, we can support the diversity of thought and needs that exist in our community. By centering what matters most, we can support each individual to live their best life in the era of COVID. Let's break that down. Next slide. So SARS-CoV-2 is the coronavirus virus that causes the infection, which then is in charge of creating COVID-19, the disease. The disease is unique in each person. Some have no symptoms and some have lost their lives. It spreads through the air and causes infection through our nose, lungs, mouth, stomach, intestine, and eyes. It takes advantage, therefore, of where we work, play, and learn and live, also known as the social determinants of health. It challenges and suppresses our immune system, causing a short-term and in many, a long-term disease state. And it has disproportionately taken the lives of people of color and specifically Black folks in the St. Louis region. Next slide. Supporting informed choice in the setting of all the challenges that coronavirus presents requires respect for the individual. First, we need to recognize the way in which there is a reasonable distrust that exists for people of color and Black folks based on not just historic, but current racial medical trauma. To combat that, we need to provide an inclusive body of information which meets people where they are. Beginning with a focus on a healthy immune system is a win-win-win in the era of COVID. This includes things like food, sleep, nutrients, vitamins, hydration, stress, hygiene, and management of chronic health conditions. We can't stop encouraging people to have physical distance, face coverings, and awareness of their exposures, as we don't know what COVID will do in this next era in which we have an option for a vaccine. Support for an informed choice about the role a vaccine can play in living with COVID-19 in our world starts by asking people what matters to them most, rather than trying to coerce a pro-vaccine posture. Next slide. To reframe the narrative, perhaps we can ask these questions instead. What are some effective and accurate talking points about the role of vaccination for COVID-19 that will support informed choice? How are organizations working together to assure accurate, responsive, and real-time information is equitably accessible to our communities? What public health campaigns are being organized to assure that our communities have access to education and resources to support a healthy immune system in the evolving era of COVID-19? Next slide. In conclusion, by focusing on what matters most and meeting people where they are, we give power to the individual to not just make a choice, but to believe in the choice they have made. They must be given the opportunity to pursue a healthy immune system capable of combating novel coronavirus, no matter what the future brings. That means education, resource, and solutioning, which address the social and structural determinants of health, including racism itself. Individuals must have access and accessible information to make informed choice about the role that receiving a vaccination might play in supporting a healthy immune system. Equitable access to that information is as important as access to the vaccination, so that individuals can make decisions which align with what matters to them most. Next slide. I am excited that PrepareSTL is going to continue using the multiple rich education, resource, and solutioning type outreach, advocacy, and collaboration it's already done through the beginning of this pandemic to support our communities and to aggressively advocate for the experiences of people of color and specifically Black folks. I know that this is just the beginning, and I'm excited to be collaborating with the RRT to provide real-time, up-to-date, reliable information for people, no matter where their starting point might be. Thank you, and I'm really excited to hear what questions come up during this panel.
Thank you so much, Dr. Punch. It's not often in a webinar that I'm going to actually suggest that we just stop and pause for a second, but I really do. I think what Dr. Punch just shared with us, and for some of us, that reframing, you might need a moment just to let that sink in. That reframing on informed choice, that reframing on making sure we have accurate and factual information to share, and thinking about the approach that we use to do it. To help us have actual and factual information, Dr. Liang is going to come on and talk more about the vaccine itself, giving some information on how it was developed, what we know, and acknowledging what we don't know. So Dr. Liang, I invite you to come on and we'll learn from you.
Great, thank you very much. Thank you, Dr. Punch, for setting that critical framework for our discussion today. And good afternoon to everyone. It's a privilege to be here to share a little bit about what we know about vaccines, especially the COVID-19 vaccines that are coming through the pipeline. So what exactly are vaccines? Many of you probably have had experiences with vaccines in the past, but traditionally what this entails is a vaccine introduces a weakened or a killed form of a virus to the body. Your body then reacts to that piece of the virus or that virus, and it stimulates your immune system to develop antibodies in response. And so that the next time that your body comes in contact with that virus in the world, your body is now able to respond to that virus and mount an immune response to that. As far as kind of the traditional framework, the traditional timeline for development of vaccines, as you can see here, vaccines take a long time to develop, anywhere from 3 to 8 years just to figure out whether the vaccine works in animals, whether it has scientific validity. And then from that point, jumping into phase 1, 2, and 3 trials in human beings. First to determine safety in phase 1, followed by safety and response, so the body's response or immunogenicity to the vaccine. And then finally, large-scale studies involving thousands, sometimes tens of thousands in the case of COVID-19 to demonstrate efficacy of that vaccine. The COVID-19 pandemic has obviously compressed this timeline, but not at the sacrifice or expense of safety. The same rigorous standards for high quality apply, just as they have with normal approvals of vaccines over the years. It's just that thanks in part to a lot of different factors, things have happened a lot faster. So number one, we have a public health emergency, and that has really generated lots of resources and lots of attention into rapidly developing these vaccines and also studying them in large trials. On top of that, we've had high enrollment in clinical trials, and that's partly because of, again, the resources that have been put into funding the studies. And then also, we've also had a high number of cases. So we're in the middle of a pandemic, so there have been a lot of COVID-19 cases in the community, and this has allowed scientists to reach endpoints much sooner than they would typically do in a normal clinical trial of a vaccine. Next slide. So as far as the two front runners in the vaccines, obviously the two vaccines that have emergency use authorization at this point in time, these are mRNA vaccines. And these are a little bit different than the traditional vaccines in the sense that with an mRNA vaccine, what we do is we provide a blueprint to your immune system of a piece of the virus. So in this case, a part of the virus has been identified, the spike protein, which you may have heard about, which allows this virus to attach to parts of a lung and cause infection. We've now been able to develop a blueprint of that spike protein, introduce it to the immune system, and then allow your immune system to react to it. So this virus itself does not actually involve the full virus, any kind of live virus, or even a killed version of the virus. It involves a very small piece or signature of the virus. Like I said before, we have two vaccines that have reached emergency use authorization and are now being used. One of them is already in use widely, and that's the Pfizer vaccine. Followed by that, the Moderna vaccine was recently approved and is also going to be kind of implemented. Next slide. So I want to just show you kind of a thumbnail sketch of some of the data of what we know about these vaccines. So for the Pfizer vaccine, this is obviously the first one that reached approval in December. And this is the large study that was done that kind of demonstrated the results, the efficacy of this vaccine. Now this study, this randomized clinical trial involved more than 43,000 participants across several countries, Argentina, Brazil, South Africa, and of course, the United States. And you'll see here on the right side, kind of the breakdown of the population that was enrolled in this study. You'll see that they're about 10% from Black or African-American background. And then also, in addition to that, about 27% from Hispanic or Latinx background. So populations of color were well represented in this study in addition. As far as the way the study was developed, this was basically a study comparing the vaccine versus a placebo. So those who received the test vaccine versus a sham administration by intramuscular injection at day 0 and day 21. So this is a 2-dose vaccine. Next slide. As far as what they found, I mean, this graph kind of demonstrates, kind of illustrates the finding here. With this vaccine, they demonstrated 95% vaccine efficacy at 7 days after the second dose. And what you see here, I'll try to describe a little bit better. But basically, those who received the vaccine in red, very quickly, you can see the departure between the red and the blue lines. So blue lines are those who received placebo versus red who received the vaccine. And on the y-axis is the number of infections. So number of new symptomatic COVID-19 infections. You'll see that those who received the vaccine had significantly lower number of infections compared to those who received placebo. As far as the safety profile, you probably have heard a lot through the news that many folks who have received this vaccine have reported short-term mild to moderate pain, usually at the injection site, as well as fatigue and headache. And this was also seen in the study as well. In terms of serious adverse events, they were actually exceedingly uncommon in this case. And we also know that from our post-trial data within the first week of the administration of this vaccine to approximately 1.9 million persons across the country. This is the week of December 14th to 23rd. Only 4,000 adverse events were reported. That's 0.2% of 1.9 million persons who were vaccinated. Of those, 21, so 21 out of 1.9 million persons had a serious adverse event, specifically anaphylaxis, requiring additional medical care, significant medical care. So all things considered, this is a very safe vaccine. Next slide. I want to talk a little bit about the other vaccine, the Moderna vaccine, which also uses the same technology as the Pfizer vaccine. So this is also an mRNA vaccine. And this trial was also multi-centered, involved 30,000 participants, primarily in the United States. And this again compared the vaccine versus a placebo by intramuscular injection at day 0 and day 28. So again, a 2-dose vaccine. And you'll see the breakdown of that study as far as the composition. Those from a Hispanic or Latino represent about 20%, and those who are Black or African American represent 10%. So about 30% from communities of color. Next slide. Again, you'll see with the blue line now, the blue line is those who have received vaccine versus the gray line, which is those who received a placebo. You'll see again the significant reduction in numbers of symptomatic COVID-19 infections in those who received the vaccine, between 93 and 94% vaccine efficacy. And this is after 2 weeks after receiving the second dose. The safety profile, again, kind of similar symptoms that they saw with the Pfizer vaccine. So pain at the injection site, fatigue, myalgias, which is muscle aches and headache. Again, serious adverse events were exceedingly rare, 0.6% in both. Now, this vaccine just received recent emergency use authorization and is still being kind of rolled out. So we're still waiting for kind of the post-clinical trial data in terms of safety and any adverse events from that vaccine. Next slide. So when we think about vaccines, you may have heard the term herd immunity. And what that means is that the goal in many cases of rolling out a vaccine is to try and build immunity within a community such that if we vaccinate enough people, we can also protect those who are not able to receive the vaccine. And really with COVID-19, the number of people needed to be vaccinated or immunized against COVID-19, the virus SARS-CoV-2, is estimated between 60 to 70%. And there are lots of unanswered questions about the COVID-19 vaccine. I want to be clear that these clinical trials, the endpoint of these clinical trials was symptomatic illness, meaning in terms of the efficacy, we're looking at prevention of people from having severe COVID-19, so ending up in a hospital or an ICU. That was the primary endpoint that they were looking at. We're not necessarily able to look at the infection, how many people were infected with COVID-19, but again, how many people got seriously sick with COVID-19. Also, we're not really sure how long the immunity lasts with COVID-19. We believe immunity with the vaccine itself is going to be long-lived, but we don't have the data yet. We're only 6 months into many of these clinical trials, and the data is going to continue to be collected over time. Obviously, we've had a short period of time in terms of experience with safety data, but these large trials involving tens of thousands of participants do support the belief that these are safe vaccines. And there's still there's still a lot to be learned. We're still only about a year into this pandemic. The vaccines themselves, very young. There's still a lot to be learned, but certainly lots of promising data that's coming through.
Thank you so much. Dr. Punch, I will invite you to join us on screen. Clearly, we're all learning to live in a new world, and webinars and Zooms and technology. And so some of those slides got a little jumbled at the end. We will work on that and share that with you all a little bit later. But now it gives us the opportunity to have a little bit of a conversation. And again, we had a lot of folks submit questions ahead of time. Serena alluded to those questions early on, and somewhat as the most popular. But there was a lot of questions about the word safety. Some folks are, again, we come from, and everyone on here, the hundreds of folks who have registered come at different starting points. Some folks are very direct and say, is the vaccine safe? ? And almost are looking for a yes or a no. Other folks come with a lot more behind what the word safe can mean. And I would love, with what you all just presented, there's a data aspect to safe, there's a community aspect, a personal aspect to safe and safety. So I really, and Dr. Punch, I'm taking one of the things from your slides where you talked about reframing questions and thinking about what are some of the most effective and accurate talking points. We have an audience of leaders today who are going to be having these conversations. So I would love for you all to think through that safety and safe and give some of your reflections to us.
Go ahead, Dr. Liang. I have some thoughts, but you should go first.
Thank you. So I guess, I mean, safety is definitely a nuanced word, I would think. I mean, as far as medical safety, when you think about the trials and kind of looking at the hard endpoints of serious events like anaphylaxis, which is a life-threatening form of allergy to a vaccine or a medication, the studies would suggest that the number of those serious events are exceedingly low, exceedingly uncommon. And we've seen that those are more, if they're going to happen, they are going to happen in folks who have had a prior history of reactions associated with vaccines, whether it's a flu vaccine or other vaccines throughout the years. So usually those who have had a risk factor are going to be at higher risk for having some kind of reaction. As far as safety for the individual, it's when I think about whether you're going to get a disease, sometimes it's either you get it or you don't, right? 0% or 100%. And as far as COVID-19, the disease itself, we know that 20% of persons, unfortunately, with COVID-19, will have a very tough course with it. We know that the mortality is obviously in the single digits, but still a lot of people will get very sick and end up in the hospital in the ICU with COVID-19. And it does become a personal decision as far as how you weigh it. I can certainly speak to myself and many other physicians. We've received the vaccine because we believe in the safety data. We have confidence in that data. But again, it is a personal decision.
Yeah, I think one of the frameworks that can be helpful is when we ask people to weigh the risks and the benefits and calculate for themselves an acceptable level of risk and acceptable level of benefit. Because when any treatment or outcome has a substantial amount of unknown, what matters is that we believe in the choice we made. It makes it much easier to understand the consequences of our choice. And so I think it begins with understanding your immune system. If you have an immune system that tends to be overly sensitive or an immune system that tends to be suppressed, you need to have a conversation with your doctor about this vaccine. That is the advice I'm giving all of my different friends, right? The ones who are either have an autoimmune disease or ones who have a suppressed immune system. And I really encourage that. The other thing, though, I think if you don't have particular concerns about your immune system, is to think about, what am I willing to continue doing in this category of COVID prevention that has minimal risk for me versus what am I willing to do in this category? So for instance, if someone makes the choice to not pursue things like, I don't know, wearing a mask, do they have to think differently about the vaccine? Now, I'm not going to suggest anybody think differently about wearing a mask. I think face coverings are part of our life now. But it's for each individual to sit and say, where is the risk? Where is the benefit? And what choice can I commit to? Because it's the level of commitment to the consequence of the choice, which really, determines our well-being. And I think that's a very powerful reframe for this question. And the other thing I will say in terms of safety is, and I do have to amplify what Dr. Liang just said, if you look at the statistics about people who have received the vaccine, it's not a large amount of people, but it's a sizable amount of people. And you look at the statistics about people who have gotten COVID, the chance of death, unfortunately, is not insignificant with COVID. And if your exposure, right, if your exposure risk to COVID is high, then you have to just consider that as you make your decision.
I like this. I have two follow-up questions on things that you both just said. One is talking about that risk for severe COVID. Dr. Liang, you presented information that this vaccine was designed or studied at the prevention of severe COVID. We do have a bunch of questions on the information that is out there on whether folks would still, like, am I good after the vaccine? To the prevention of severe COVID, to what does it prevent it altogether? Can you still get it? If you all could provide some clarification, and again, equipping folks with that factual information to help provide informed choice, but giving some more info on what do we know at this point that it prevents or helps to prevent, and what do we not know?
Great. That's a great question, and it's something that I want to highlight, that these clinical trials are designed to answer a certain question, and oftentimes that question is kind of limited by a number of cases and also resources and other things. And these clinical trials, specifically, the question they were designed to answer was, can this prevent serious COVID-19 or symptomatic COVID-19? And they did answer that question for sure. The question of whether these vaccines prevent infection with SARS-CoV-2, the virus that causes COVID-19, we believe that is going to be the case, but these studies were not designed to do that. In order to do that, it would require even more resources in terms of kind of testing 30,000 people on a weekly basis for whether or not they were shedding virus or becoming infected. So every study is going to have its limitations. It's really important to kind of emphasize those limitations. That being said, we do believe number one, the studies do demonstrate that the vaccines will prevent serious COVID-19, symptomatic COVID-19, and we are pretty certain, we are pretty confident or optimistic that they will also prevent infections, and certainly, obviously, serious infections.
How would either of you provide information on right now, as far as I know, and I'm learning from you all, we will be advised to continue, for those folks who make the choice that for them they would choose a vaccine. There is the knowledge or the things out there now that we will continue to wear masks. Why is that with a vaccine?
You know, like with any vaccine, when we think about influenza, so flu vaccine, it's not that the vaccine 100% prevents the infection. It prevents a lot of infections. It prevents a lot of serious infections that land people in the hospital. If you're going to get infected with influenza virus, if you're unfortunate enough to be infected and also vaccinated, your likelihood, your disease, your infection will be very mild in contrast to the alternative if you were not vaccinated. So, you know, does the vaccine itself replace the use of masks and distancing? No, and that's because there's so much disease around us. You know, in our community, there's lots of transmission going on. So your likelihood of being exposed to someone with COVID-19 is significant. You know, with time, we hope that as transmission in the community goes down, some of those those tried and true infection prevention strategies will be the requirement for those or the need for those will decrease. However, at this point in time, the vaccine itself will not replace those strategies. They will work in addition to those and complement to those strategies.
I want to break down a really simple concept that I emphasized in the beginning, and it's even more important in the pandemic now. An infection is caused by the virus. The disease is the result of your body's response to that infection. That's why tending to your body's response with a healthy immune system is the single most powerful thing you can do, besides creating a barrier for you to either spread or experience the virus. The reason why I would suggest continuing face covering is twofold. Number one, you do not know if you can get an infection that's so powerful, there's so much virus, it overwhelms your immune system, even if you got a vaccine or had COVID before. But you don't know if you could get enough of an infection that you would end up giving it to someone you love. This is why you have to think about what matters to you most. For most people, they'll say it's the people around them in their life that they love. I don't want to give the infection to my child or my mother. And so regardless of whatever is happening to me and how like gangbusters my immune system is, I don't trust with what we know about coronavirus right now that I don't have the capacity to give it to them. And so if I have a concerning exposure, I'm going to distance. If I am worried that I have symptoms, I'm going to distance. And I will do my best to cover my face in all public settings, no matter what is going on for me. Might this information change 6 months from now, 12 months from now? Sure. But right now, it is ingenuine to say that if you have had a vaccine, the infection is out of the question, because it's not.
I think that's great information. Again, we have a lot of folks on here who are leaders in their community, in their organizations, and will be looked at as someone that someone might go to in a relationship of trust to ask these questions, to get this information. We do have questions coming in the Q&A and in other formats. There are questions. One of the things that you all, in the roles that you have and questions, you are always having people come to you with, well, I heard this, or I heard this, and it could be from secondhand or from the news or from this. We do know that there is viruses mutate, and the COVID virus, there is a known strain that's mutated. I have questions in the Q&A from the South Africa Great Britain. It's already appeared in some states in the United States. What do we know about the vaccine and this new strain or this mutation?
So the answer here is that we're still learning a lot. They have tested the recent UK strain against the Pfizer vaccine, and there have been no concerns. You know, a lot of thought has gone to developing the vaccines. These folks have kind of identified what they think is a part of the virus that is not going to change. We hope it's not going to mutate. So that's something that will be common to all of these viruses, but time will tell. But at this point in time, these mutations, really, I think the main concern with them is that they spread a lot easier, and this is adds even more kind of intensity to the need for masking and distancing and other preventive measures.
The way I think of it is like the spike protein, which the vaccine is toward, is like Android or iPhone. Like it's one of those two flavors. There might be upgrades, there might be different versions, but it's going to plug in basically the same way because it's such an essential component of the virus. So thankfully, the science focused on something that should be a stable part, regardless of the ways the virus changes over time. Again, something we hope, but we don't yet totally know.
Mm-hmm. We do have questions. Dr. Liang, one of your slides showed how many vaccines were put into trials and have made it through various steps. There were a number of questions about vaccines still to come. And of course, we don't know how all of those studies and things that will work, but we certainly know there are more coming. As they do, obviously, this is point in time today. How do we advise folks to process that information if it makes it through the same process?
That's a great question. I mean, I think that both the Pfizer and Moderna vaccine have the most data for them and are probably the ones that are most likely to be used widely here in the United States. But there are other vaccines that are coming online that work a little bit differently. As far as the other ones, they work differently. As far as the risk of them causing infections, there's no concern, at least with the ones that I've seen in terms of causing infection. Their efficacy, so their ability to prevent infection, that's still being kind of hashed out. So they're still in the process of conducting their large clinical trials, and we will see data coming out of those. Actually, some have come out in the last week, but I would imagine over the next couple of weeks, we can probably provide additional guidance based on those published trials about these additional vaccines.
Fantastic. We do want to make sure that we can keep going, but I would like to ask both of you, as you think about the audience that we have today, folks that are leaders in their own communities, their own circles, they took the time to sign on today, so this is something they want to learn more of. As you think of this reframe of empowering, especially organizations, employers, these are a lot of nonprofit and social service sectors, to really enter in these conversations. There are some opportunities to, Dr. Punch, you alluded to opportunities in this in addressing or having better understanding of social and structural determinants of health, including racism. So I'm going to leave you all with 1 or 2 minutes apiece. Really, what is your best advice or your best pieces of info for that effective and accurate talking points leading to informed choice? Dr. Liang, I'll have you go first, and then we'll have Dr. Punch.
Oh, that's a challenging one. Informed choice, knowing where to find reliable information. So number one, going to the science, going straight to the data, being able to understand data, knowing who to ask when you need help interpreting data, and who are your trusted sources of information, be it your primary physician, other specialists and so forth, and certainly kind of vetted websites online with data that's accurate and reliable. So I think that's probably the most important thing, is knowing where to get the right data from. And certainly all of us, we want to serve as a resource. If we don't know the answer, we will do everything we can to get you the right answer.
I would encourage leaders across the region to embrace with humility a posture of radical listening. To understand how to resource and support those we serve in leadership, we have to understand their priorities and what they care about. When I have thought about how to serve my community of friends who are all making decisions about this virus and vaccine, I first started by asking them, what matters to you most? I've heard everything from, I want this vaccine yesterday, to I will never take it. Hell no. And I am able to find a way to meet them and support them in their choice, no matter what. Because I've decided in my leadership to center their priorities. It is a time for us to hear our people and love on them in a way like we've never before by centering their interests, their families, their hopes, their needs. And I know if ever there was a time, this is the time to do it. And I believe we can.
Well, I can't thank the two of you enough for joining us and having this conversation with me. We know there are so many more questions. We will continue these conversations in the future. PrepareSTL and RRT will keep looking for avenues and platforms to share this accurate and factual information. We are going to pivot right now. This is a point in time conversation, and at this point in time in our region, whether you are tuning in from Missouri or Illinois, there is vaccine available. We do know we have both the Pfizer and Moderna vaccines approved and in our region. So we do have two folks joining us, and I'll ask Dr. Randall Williams and Mr. Philip Pugh to come on screen and join me. We're really thrilled to have them both here. I'm going to quickly transition because I happen to know that Dr. Randall Williams, who is the director of Missouri's Department of Health and Senior Services, only has a few minutes to be with us. There he is. We've asked them both to come on here. They have a little bit of a different relationship with their individual state plans, but Dr. Williams is going to give us an overview of where Missouri is with their state plan for the distribution of vaccine. And I do know he has to go, so he has a limited amount of time, but I'm going to turn it over to Dr. Williams first.
Well, thank you, Karen, and thank you everybody for inviting me to be on. I do apologize. I have to go to another call at 4. We just had a big announcement about our rollout that we have activated phase 1B, tier 1 and tier 2. So that's occupying much of my day communicating that message. But just greatly appreciate everyone taking the time to learn about the vaccine and appreciate the excellent presentations I just heard. What I would tell you is that we have 190,000 people who've been vaccinated in Missouri. We are finishing up phase 1, which is our long-term care facilities and their residents and their staff and healthcare workers. The governor has been incredibly purposeful about trying to protect our most vulnerable. And while our residents of long-term care facilities only make up 4% of our cases of COVID-19 in Missouri, they make up 40% of the deaths. So we get up every day worried about them, but we're very thankful that we've allotted all the vaccine, all 1,300 nursing homes in Missouri have signed up to be vaccinated. And so we'll be finished with that in another week. We're then going to shift.
Frontline healthcare workers getting their first dose of the COVID.
We're going to shift our vaccine to finishing up the rest of our nurse practitioners and nurses and doctors and PAs and finish up phase 1A and then move into 1B today and also on Monday. And so I just want to take a second to talk about that. 1B tier 2 is every Missourian over 65 and any Missourian that has other diseases like heart disease or kidney disease or diabetes, even if you're just 30 years old. But because we know from data that those patients are most vulnerable to becoming severely ill. We are incredibly sensitive to the fact that some populations appear to be more vulnerable. And certainly as we work with Fred Eccles in St. Louis and Spring Schmidt in St. Louis County, we're greatly appreciative of leaders in the legislature, Senator May, Senator Roberts, helping us very much do clinics that are incredibly user-friendly. So next Saturday, I'll be at Southside Wellness Center vaccinating people. I'm a doctor, I can vaccinate people. So we're going to vaccinate 400 people there over the age of 65 at the Wellness Center there. And we have 5 more similar clinics where we will go into communities with Senator May and Senator Roberts, having picked them, and do those vaccinations. So incredibly thankful for the leaders there. I do want to reiterate the incredible importance of autonomy that we think that is in, I practiced medicine for 30 years, delivered 2,000 babies. And we just think that patients have rights. They have rights to be informed, and then they have rights to make decisions. And so we're incredibly respectful of that. So I just want to reiterate what we said at the very beginning of this is that no patient should feel like they should have to do anything. They should feel like they have a right to be educated and informed and then make the best decision for them. And everybody's different. So greatly appreciated the sensitivity to that, because I do think that's incredibly important. And with that, I will stop. We do expect to hopefully have 2 more vaccines here in Missouri in February, the AstraZeneca and the J&J. We don't know how much. We do hope that we will be finished with the universe of 2.5 million in 1B by end of March, and then move into phase 2, which is a smaller population. And then phase 3, which is everybody else, we hope will be able to get a vaccine in mid-April. And everybody in Missouri who'd like to get a vaccine, we think will be able to have one by July. So we are committed to making it as easy as we possibly can. I'm going to leave you with 2 websites that I think are really good. The first one is mostopscovid.com. And that's everything that we know about the vaccine. And the other one is health.mo.gov/coronavirus. And that second one is just everything about COVID-19. The first one's about the vaccine. And so if you think you'd like to get a vaccine or learn more about it, I would go to mostopscovid.com, see if you're eligible, if you're over 65 or you have heart disease or kidney disease or diabetes. And then if you are, tomorrow we will list all the vaccinators in Missouri, every place you could go to get a vaccine. And so if you're eligible, you would contact one of them, see if they have vaccine yet, and get your vaccine. So with that, I'll stop. Again, I do apologize. I've got to go off the phone, so I won't be able to answer any questions. But if I can help you in any way or the department, I appreciate our colleagues in Illinois. And I'm going to jump off now. But again, you're very gracious to have me on. Thank you.
Well, thank you very much. We do plan future conversations when we can on more specifics. Obviously, today's conversation with lots of social service providers, we're asking a lot about the definition of essential workers and when some of their folks would be included. And we'll certainly emphasize that the state released more information on that group called 1B today. And so we'll be looking for more information from you, but I do realize you need to go, and we'll have more information about more vaccine in the state and in the region in the coming weeks to come too.
Thank you.
Thank you. With that, knowing that Dr. Williams has to drop off, I do want to switch gears. We do have many folks on this webinar, and our RT is committed to serving the region. So we want to make sure we get an update to and an overview of Illinois' plan. I'm thrilled, to have Phil Pugh here. He's the Director of Emergency Management at Memorial Regional Health Services. So I will be the first to say, we know you are not quite the same as Dr. Williams, that you are responsible for the state plan, but we do have you coming to us today as someone who intimately knows and has been working with Illinois state plans. So please give us an update and we'll go from there.
Thank you very much, Karen. So from an Illinois perspective, we are
fairly in concert with all of Missouri, the 1A, 1B, all of those phases, we're right in line. And for the Illinois side, we're probably going to be transitioning on or about the 18th. There are some, the 18th of January, to get to that 1B category that Dr. Williams described earlier. We'll start to move over into that around the 18th. And it will look maybe slightly different on the Illinois side. And primarily that's because of how our distribution model works. Logistically, you've probably seen, whether it's on national news or local news, how difficult it has been to get the Pfizer vaccine, which has to be at an ultra cold state, into the hands of very rural communities. Not only am I the Memorial Hospital Emergency Preparedness Emergency Management Director, but I am also the Healthcare Coalition Chair. And we have 11 counties, 11 counties and 20 hospitals that we're working with, and associated health departments. And the way Illinois is working is that they're sending a lot of that ultra cold vaccine, the Pfizer specifically, to the regional hospital coordinators, of which I am, and Memorial Hospital is, and we are redistributing that to our communities here across the lower part of the state. So in our 11 counties, we're getting stuff out to Randolph County. We're getting stuff all the way out to Fayette County. So that's another logistical layer that we have embedded in the plan here. So while we've worked out all the kinks in that, and that seems to be rolling very smoothly, you know, a lot of folks are like, when can we get more vaccine? When can we get more vaccine? What I can say is that what we do have, we are using, and we're using it at a rapid rate. So those things are going very well. As we move from 1A to 1B, the next question is, what's 1C going to really look like? Well, I can tell you this, that the state has done a very good job at putting together scheduling components and allowing the standard citizen, once we get to that level, to be able to register online, go out and get a ticket and find a location. So a lot of that information is still to come and be publicized, but the Illinois team is working, you know, desperately behind the scenes, 24 hours, 7 days a week, until all of the kinks are ironed out. Since we've started, we've received several thousand doses of the vaccine. We're approximately 75% through 1A, which is great for us. And some areas are moving into 1B and testing out those small, you know, differences and getting those hiccups out the way. So, and that's going very well. As it stands right now, once we get into our 1B, we'll have about 2.6 million folks to get through. And that's going to take us probably April, May-ish timeframe until we can get to the general citizenry. So, but I'm a firm believer that as we do work out those kinks, that we'll be able to probably move at a more rapid rate a little later. Other than that, I mean, things seem to be going very smoothly here in the region and with our partners in St. Louis, just across the river. So I'm super thankful for groups like this and hearing Dr. Liang and Dr. Punch, you know, passionately, you know, get that information out there. And one thing that they said both is that information is key, and being able to find a good, true source of information. On the Illinois side, I recommend everyone go to the IDPH website, because they have all of the vetted links that you want to get your information from. And that's simply dph.illinois.gov/COVID-19. That's where you want to go. That's where you want to get your information. And that's where they're going to begin to populate all of the open sites where you'll be able to get vaccine and where you can register. So you want to use that as your, you know, your sole source of truth for the Illinois side. Don't go to a ton of other links unless it's been vetted through that.
I will tell everyone, we know we've had some technical difficulties and the slides are no longer seem to be accessible. We are putting those resources, the website for Illinois, the websites that Dr. Williams highlighted for Missouri, we will make sure they get out to you. They are being put in the various formats, depending on how you tuned in with us today, trying to put those websites out. Philip, since you are still with us and you're not hopping off, we have lots of questions coming in, and I know lots of folks have questions on the distribution. This is always a struggle when we're having a point in time conversation, and today is really that overview to include and focus on some of those initial conversations first. So we will have to seek out other opportunities because we value your time, and we know you all only arranged to be with us for a couple more minutes. But there have been some questions. We talk about St. Louis as a region. We have folks who live in Missouri and work in Illinois. Some folks who work in Illinois and live in Missouri. Is there a rule, or is there anything that about where someone receives a vaccine?
There isn't a hard and fast rule, but the allocations have been broken out based on the population census, the last population census, as well as the working community. So those who may be, I work in the BJC system, but I have a few folks here in my office that live in St. Louis, but they work here. They got all their vaccinations here. And that's to be expected. We have a huge population with Scott Air Force Base here as well. And a lot of those folks come from the St. Louis area. They are included in those numbers. I'm guaranteeing you there's not going to be a hard and fast rule that's going to say, oh, you live here, you can't get the vaccine. No, that's not going to happen. We're trying to get as much vaccine as we can out. There may be some changes in the future, depending on, I don't want to say the next administration, but there are some thoughts about pushing out more vaccine of single dose vaccines to get it out quicker, because as both doctors referenced, this is a 2-cycle vaccine. You get one vaccine and you get another one 21 or 28 days later, thereabouts. There is some communication or thought behind potentially just pushing more vaccine out, getting as many single doses out, but that's still to be debated. As right now, we're going to be 1 dose, 2 dose, and nobody's going to shake a finger at you and say you can't get a vaccine in this location. So no worries there.
I do see a number of questions coming in. I saw a couple people had technical difficulties. For folks who live or work and had questions on the Missouri thing, the release today is 1 tier of 1B. The plan itself can be a little complicated if you haven't seen it yet. All the states have very similar phases. Phase 1 is what we've been concentrating on, and it was phase 1A in both states. We are getting closer to 1B. In Missouri, they have said that we will now include phase 1B tier 1, which happens to be EMS folks and some public health folks. All of that can be laid out on the websites being shared in all of the chats or Q&A on whatever platform you are joining us on. We know this is complicated. We know folks that have with social services and nonprofit organizations want to know when their staff might be eligible. We will create opportunities, especially for those members and those of you connected with the RRT, in future meetings and weeks to get more of that information to you. Philip, I can't thank you enough for joining us today and sharing the information about the state of Illinois' plan. We know you have questions. Please continue to populate those in the Q&A. We will keep them and we will use them to guide us for future meetings, panels, podcasts, whatever else the creative folks in both organizations are going to keep doing to help get factual, actual information out there to help each person, each organization, all of us make informed choice. At this point in time, I'm going to ask Katie Kaufman to join me on here. She's a colleague of mine with the regional response team. She's going to talk to you all about next steps for our future conversations and get your feedback from today. Again, Philip, thank you so much. Thank you to Dr. Randall Williams, to Dr. LJ Punch, to Dr. Stephen Liang. This was an incredibly useful conversation. I certainly hope those of you who joined benefited and can take some things from it. And we look forward to continuing this conversation in the weeks and months to come.
Agreed. Thanks, Karen, and thanks to everybody who participated today with the event. My name is Katie Kaufman. I'm a member of the regional response team staff. I'm a loaned staffer from the United Way of Greater St. Louis. So, and my role has been to work with our members. The regional response team has really been about coordinating organizations who want to be part of the equitable recovery of our region, both in directly addressing the COVID-19 pandemic, as well as addressing the systemic racism within our community. And so as you are reflecting on what you've learned today, maybe how you've reframed your own thinking today. We encourage you to take a look at the survey that's in the chat and provide some feedback to us. As has been stated multiple times, this is the beginning of a series of panels that are part of our effort to educate, bring factual information forward, and future panels will look at going deeper into what we know about distribution in each of the states, but more importantly, focusing on making an informed decision on if the vaccine is right for you, as well as what the nonprofit and social service community's role is in equitable distribution of both information and the vaccine to those who choose to take it. We are, again, so grateful for the partnership with PrepareSTL and continue to do our part to engage with the social service sector to get this information out. Many of you today are registered through the Eventbrite link that came out, and for those that did submit their email address, the more than 500 individuals there, you will receive a follow-up email with many of the resources, including the recording to today's event. And we will encourage you, if it makes sense for your organization, to join with the response team, certainly by going to the website c19rrt.org, where at our Get Engaged page, you can find the link to our Collaborative Action Network letter of commitment that your organization can sign if you are not already a member organization, or in the contact link to share your email information so that we can put you on our newsletter and you can receive information going forward. Beginning in February, we will be digging in deeper with our Collaborative Action Network membership to really think about and take action on our own roles in being accountable to making change that enhances the well-being and the recovery efforts of our community. And so again, we invite you, we thank you for joining us today. This may be your first time, or it may be a dozen times that you've been engaged with the RRT over the past 10 months, but we welcome you to join with this work. Systems are run by individuals, and each of us has a role to play in these networks. And so be part of this learning experience with us. Please join us on this journey. And I encourage you again to provide some feedback to us through the survey link and to join us at a future meeting going forward. I believe that this is the last part of our event today. And so thank you for joining us. We look forward to our continued work together with PrepareSTL, the regional response team, and you.